Welcome to Dermoscopia's presentation on common skin lesions. Despite the name of our project, we won't be discussing dermoscopy here, but if you'd like to find out more, please check out our online resources where you'll find information including pre-recorded presentations covering this topic. We're going to focus on the macroscopic appearance and diagnosis today. The first thing I want to get across about examining for skin lesions is to look for the thing that shouldn't be there. Often in a sea of noise, one thing will stand out because it looks different to the rest. It may not be the largest lesion, but it will look different. This is the ugly duckling sign. That is the skin lesion that is not in keeping with the rest and looks like it shouldn't be there. So when faced with many benign lesions, it's important to take a step back and look at the whole picture before focusing in on the specific lesions that draw out attention. The ugly duckling may not be a cancer, but it deserves closer attention. We'll start with common benign non-melanocytic lesions. So back to this man's back. Peppered with these lesions, they are all seborrheic keratosis, including the ugly duckling, known by pathologists as their proper name, basal cell papilloma, or as the lay term senile or age-related warts. They occur across all Fitzpatrick skin types with equal frequency. They are very common. They are age-related, and everyone will get some if you live long enough. The tendency to get loads runs in families. You'll find in some textbooks a description of the sign of Lézard-Trélat, a supposed association between lots of seborrheic keratosis and internal malignancy, but most modern dermatologists will say that this is likely a metaphenomenon. That is, lots of seborrheic keratosis is associated with being old, and being old is associated with internal malignancy. They are described as flat-topped, stuck-on lesions that look like you can pick them off, said to have a greasy appearance, though not actually greasy to touch, as they're nothing to do with sebum, despite the suggestive, old-fashioned name of seborrheic keratosis. Here's that ugly duckling from the first photograph, looking greasy, stuck on, with a grainy granular appearance with surface pits and crevices, and looks like it could be picked away. This is a benign seborrheic keratosis. Another with the stuck-on appearance, some surface pits and holes visible, at the periphery even some white structures which represent keratin cysts. These are little pearls of balled-up keratin in the epidermis, and are very typical of seborrheic keratosis. Often only visible with dermoscopy, but if they're large enough, can be seen with the naked eye. The pits in the surface represent keratin cysts that have reached the surface and the ball of keratin fallen out, leaving an empty crater. Here's another example in Fitzpatrick skin type 6, showing a stuck-on appearance of a lesion with very well-defined borders, a granular texture, and surface pitting can be seen, and some small visible white dots which may represent keratin cysts. This may be on a background of numerous similar matching lesions, as you can see around this lesion, or they may be isolated. Solar lentigo or lentigenes are common benign pigmented lesions, sometimes referred to as sun freckles, which are probably flat precursor lesions to seborrheic keratosis. They are more common on chronically sun-exposed sites, and they typically are well-demarcated tan-brown lesions, sometimes described as having a moth-eaten appearance, and if left will get larger and eventually warty as they become seborrheic keratosis. Despite the name solar lentigo, it is debatable whether these are related to sun damage at all, or more likely their occurrence on the face is simply coincidental, as these will almost always develop into seborrheic keratosis if left long enough. Either way, they are entirely harmless. Also, despite the name and similar appearance, they are not related to the premalignant condition, lentigo maligna, from which they must be differentiated. Treatment is not required. They are benign with no malignant potential. They can be treated cosmetically with cryotherapy, electrosurgery, or laser. This lesion was treated with a Q-switched Nd:YAG laser, showing resolution with no scarring or dyspigmentation. The next lesion I'll talk about is the benign angioma, or hemangioma, literally a lump of blood vessels. Angiomas are common benign vascular lesions. People can have many, and the variant known as Campbell-De Morgan spots or cherry angioma increases with age. Angiomas are also known to erupt during hormonal changes, such as pregnancy. They take the form of small purple or red macules or papules. They can turn to black if the blood thromboses. Their blood supply is cut off and they can get inflamed and painful or itchy very suddenly. At this point they can be mistaken for pigmented lesions, but here the history is important. If it started off as a red or purple lesion that suddenly turned black when it became painful, then you might suggest a thrombosed angioma rather than a true melanocytic lesion. If you look close enough in good light, they are usually dark purple rather than a true black. The reactive types of hemangioma, which include diagnoses such as pyogenic granuloma or lobular capillary hemangioma, these are eruptive types of hemangioma that are supposedly related to local skin trauma. They often appear as a fleshy, bleeding papule that is proud of the skin and attached via a narrow pedicle or stalk. They are common on the fingers and on the lip, and apart from a prior history of trauma, pregnancy is a known risk factor for developing these. Pregnant women will classically develop these on the lower lip, where they are occasionally referred to as granuloma gravidarum. Despite the name, they are neither pyogenic nor granulomatous. Angiomas are harmless and treatment is not required. Biopsy may be performed where they are mimicking a melanocytic lesion if the diagnosis can't be confirmed without it. If a biopsy is not required, they can be treated cosmetically with cryotherapy or laser, as in this case. The reactive type of pedunculated angiomas are usually shaved and cauterized to allow histological confirmation, especially in the elderly, where a bleeding lump must be differentiated from a poorly differentiated squamous cell carcinoma or a melanotic nodular melanoma. Next up is the dermatofibroma. These are scar-like lesions, most common on the limbs, but can occur anywhere on the body. They are described as feeling like a lentil or dried pea under the skin, probably caused by some minor trauma. One theory is, as they are common in women on the legs, that they may be related to traumatic methods of hair removal. Another theory, given the predilection for the limbs, is that they are related to insect bites. They can be any colour, but it is the feel of them that gives them away, that dried pea or lentil-like feel under the skin, and characteristically they pucker when squeezed, sometimes known as the pinch test, which confirms the diagnosis. They may have a scar-like pale centre and some light pigment-like shading around, though other dermatofibroma can be polymorphic. Here is an example of the white scarred centre surrounding peripheral pigmentation and a positive pinch test confirming dermatofibroma. Viral warts are a common benign lesion. Often people think verrucas are different, but verruca is just Latin for wart. It tends to be used by lay people to refer to warts that occur on the bottom of the feet. These are caused by the human papillomavirus. The HPV subtypes that cause these are not the subtypes responsible for genital warts, and so the oncogenic risk from these is very low. When they are on the soles, there can be a collar around of thickened skin and a rough central patch of skin. Like seborrheic keratosis, they can have a grainy, granular appearance, and there may be some small black dots visible with the naked eye or a hand magnifying glass, and these represent thrombosed capillaries. This is a viral wart with visible black thrombosed capillaries. As the warty projections are pushed upwards, they bring dermal capillaries up with them, which get longer and eventually thrombose, resulting in the black dots. Sometimes finger-like projections can be seen with capillary loops visible within them, terminating in a black streak or dot as they thrombose. These are sometimes referred to as filiform warts. Treatment of viral warts is not required and generally quite unsatisfactory. Oral zinc supplementation is a simple, cheap and safe home treatment option and more effective than home freezing kits or wart paints. Even hospital professionally performed cryotherapy is of little real-world benefit. Most viral warts will resolve themselves within 24 hours with no treatment. Immunosuppressed patients, such as organ transplant recipients, may have many warts that persist for longer, and treatment is generally ineffective. Blackheads are not an uncommon sighting in the skin cancer clinic. They are very common. These giant variants are often on the trunk and larger versions of the more typical blackhead seen on the face in patients with acne. So they can cause some anxiety due to their size and unusual appearance. You usually see a thin-walled cyst-like structure blocked with a plug of keratin, which may be quite dark in colour. No treatment is required, but you can squeeze them to express the keratin blockage, and sometimes this will cause them to resolve. Many times, though, they will just come back again, but they are quite satisfying to extract if you like Dr. Pimple Popper. Now we'll cover common benign melanocytic lesions. Freckles, or FLEDs, as opposed to lentigines, are common, especially in skin type 1. They get darker following sun exposure, whereas lentigines do not. They are not harmful. The number of melanocytes in the epidermis is normal. Now getting on to true melanocytic benign lesions, or those that people tend to refer to as moles. The terminology here is based on where the melanocytes are located histologically. So in this case, the acquired junctional nevus, the melanocytes are located at the dermoepidermal junction. These commonly occur during adolescence and young adulthood and look like small, flat, light or dark brown, evenly coloured moles, which most people get some of to a lesser or greater extent. These are not harmful, and whether benign ordinary nevi actually become melanoma is debated. They should be monitored as any mole should be, but the risk of a simple junctional nevus transforming into melanoma is probably the same as the skin next to it, as the melanocytes are no different in character. That is why removing all of someone's moles is not a sensible strategy for preventing melanoma. Compound nevi have melanocytes both at the junction of the dermis and epidermis and deeper in the dermis. This causes a mixed appearance with colour variation, and these are often raised. Macroscopically, these can be hard to tell from melanoma. Look at a patient's other moles for comparison. If there are similarities, then this may be reassuring. These are no higher risk than junctional nevi, just harder to diagnose without dermoscopy. Here you may choose to utilize your ABCDE criteria when assessing moles such as this. As a reminder, these are asymmetry, an irregular border, 3 or more colors, and a diameter greater than 6 millimeters. The added E and F are for evolving lesion, if it is growing rapidly, and the funny-looking mole, the ugly duckling we discussed at the beginning. If it doesn't match the other moles and looks like it shouldn't be there, pay closer attention. Compound nevi often fulfill some of these criteria, and so without dermoscopic support, referral or a period of monitoring may be required to check these aren't changing significantly. If there are no specific risk factors, then the patient may do this themselves with their own photographs, and apps are available to help them do this. The exception may be these. Soft, wobbly, squidgy, fleshy moles like these are very reassuring. They may meet the ABCD criteria, but if they are soft and warty like this, they can usually be left. Often they have been present since early infancy. Sometimes the characteristic is called the wobble test or squidge sign. The patient can usually be reassured and left to self-monitoring. Now we'll start with the precancerous skin lesions. Defined as partial thickness dysplasia of the epidermis, these are common, particularly in lighter skin types. They represent chronic sun damage and carry a small risk of transformation to keratinocyte skin cancers, squamous cell carcinoma, and basal cell carcinoma. Actinic keratosis appear as scaly red patches on chronically sun-exposed skin. They can appear as just indistinct redness of the face with some light surface scale, and are often mixed in with other things, such as solar lentigo and seborrheic keratosis. Treatment is not compulsory. Patients should be advised to be careful to protect themselves in the sun and monitor their skin for signs of skin cancer. If treatment is desired, cryotherapy for individual lesions can be performed, or for more widespread field change, either topical chemotherapy, such as fluorouracil cream, or a type of light treatment called photodynamic therapy can be helpful. They will always recur eventually, so repeat treatment may be needed, and patients should be warned. Once they have these, they will get more, and this will be a chronic condition that can be managed, but not to expect a cure. A step beyond actinic keratosis is Bowen's disease. This is defined as full thickness dysplasia of the epidermis, but without any evidence of invasive squamous cell carcinoma. This carries a higher malignant potential, but that risk is still relatively low. The common site for this is the lower legs, but can occur anywhere. These will usually present as a scaly, usually asymptomatic red patch, and there may be multiple patches matching it. Treatment considerations are the same as for actinic keratosis: leaving alone and self-monitoring only, cryotherapy, topical treatment, or photodynamic therapy. Lentigo maligna are precancerous for melanoma. The actual risk of transformation to melanoma is debated, but it is thought that given enough time these will all eventually become invasive melanoma. They may be indistinguishable clinically from an early melanoma and are treated as such, except that they will tend to be flat like early melanoma. They should be treated as if they are early melanoma and referred. In this example of a melanoma in situ, the lesion fulfills the A, B, C, and D of the criteria. In terminology, lentigo maligna is used to refer to melanoma in situ when it occurs on chronically sun-exposed skin, usually the face. Elsewhere, and in isolation, the term melanoma in situ is preferred. The meaning is to all intents and purposes the same. They can be hard to distinguish between benign solar lentigo, especially on the face, where they may appear amongst a collection of benign lentiginous and other sun damage. More grey or black colours should prompt suspicion, as well as rapid changes and the appearance of an out-of-place lesion not consistent with the background dyschromias. Now on to the common skin cancers. The most common solid malignant tumour, historically called rodent ulcer due to the appearance of a rat slowly eating away at a person's flesh, basal cell carcinoma, are very common. They appear typically as a slowly growing papule that eventually breaks down and doesn't heal up, forming an ulcer which gradually expands. They probably have no metastatic potential, or if they do, it is rare, and all cases reported in the literature have been disputed. They are caused by chronic sun exposure, so usually a cancer of the elderly, though we see these in younger and younger patients. Common nodular BCC starts like this, as a translucent domed lesion, which may have some visible blood vessels and flecks of bluish pigmentation. Eventually they start to break down, and the patient may complain of bleeding. Eventually they form the typical textbook description of a rolled edge, pearly or translucent in nature, with some visible fine telangiectasia, a central crater which may be ulcerated. Although they may have no metastatic potential, they are locally destructive, in this example the eye being the main risk. A basal cell carcinoma may invade and grow into and behind the eyeball, eventually with catastrophic results. Basal cell carcinoma is not common in skin of colour, but it does happen and may go unrecognised, so present later. It may be thought about for a non-healing ulcer, and consider other risk factors than sun exposure for skin cancer, such as previous radiotherapy. BCC may be more pigmented in darker skin compared to lighter skin types. Conventional treatment of most BCC is with either surgery or radiotherapy, surgery being the most common option for most people. They are excised and the area may need to be reconstructed with skin grafts or flaps depending on the site and complexity of repair. This is an example of a full-thickness skin graft for a BCC on the nose. The next most common skin cancer is the squamous cell carcinoma. These have metastatic potential, typically spreading to lymph nodes and then the lungs. Like BCC, it is a skin cancer mostly of the elderly and related to chronic sun exposure. It is a primary cancer of keratinocytes, and as such well-differentiated ones will have the appearance of a keratin-producing tumour, such as in this case, a round shouldered lump with a keratinous central plug or horn. Here is another example of a well-differentiated squamous cell carcinoma, as a round shouldered lump with a keratin plug. Squamous cell carcinoma grows rapidly and are usually painful, in contrast to BCC, which grows slowly and is usually not painful. As they lose their differentiation, they may stop producing the keratinous process and become a non-specific, painful, friable, or bleeding lump. Treatment of these is the same as for BCC, conventionally being either surgery or radiotherapy. Most have not metastasized at the time of treatment, so most patients achieve a clinical cure. Squamous cell carcinoma is, again, uncommon in darker skin, but this image also serves to highlight that squamous cell carcinoma of the lip in any skin colour is associated with a poorer prognosis, with a higher probability of early metastasis. Squamous cell carcinoma in darker skin is already associated with worse outcomes, in part due to late presentation at diagnosis. 1 in 1,000 squamous cell carcinomas will occur in patients with black skin, but despite that relatively low risk, mortality is significantly higher. Melanoma is the most dangerous of the common skin cancers. It appears on sunburned skin rather than chronically exposed skin, so prefers the back and legs to the face. They have a bias towards younger patients and can metastasize early or micrometastasize, presenting decades later with distant spread. That said, most melanoma is diagnosed in the early stages, where prognosis is excellent. Once again, turning to the ABCD criteria, where a melanocytic lesion is suspected, to help you decide if this is a melanoma or not. The most important one being the ugly duckling sign. A lesion like this one looks out of place. It is large, has different shades of brown and red and white, with an irregular border. 90% of melanoma start as flat lesions like this, called superficial spreading type melanoma. Eventually, untreated, a superficial spreading melanoma will enter something called vertical growth phase, where all or part of it starts to become nodular. This also indicates downwards invasion, and this is a bad prognostic sign. Note the nodular element to what probably started as a superficial spreading melanoma. Multiple colours: brown, black, red, white, asymmetry, a large size and irregular border. At 5 o'clock there is a small red dot which also probably represents a cutaneous in-transit metastasis. Here is another superficial spreading melanoma, becoming nodular in the centre, demonstrating black, brown and red with irregularity of the border, asymmetry and a large size. 10% of melanoma misses the superficial spreading phase, and these are called true nodular melanoma. They start as a nodule and invade deep early. They have a very poor prognosis. This type of melanoma is commonly amelanotic, meaning it has no pigment and may present as a non-specific bleeding nodule, or they may present like this, a black nodule with no other distinguishing features. A non-specific friable bleeding nodule must be excised for histological confirmation to rule out both poorly differentiated squamous cell carcinoma and nodular amelanotic melanoma. Melanoma has a preference for the young, though incidence still rises with age. It is the number 1 cancer killer in women aged 20 to 40, and overall the number 3 cancer killer in the UK, after breast and bowel, smoking cessation having knocked lung cancer out of the top 3. The incidence is still rising. The main risk factors are family history and childhood sunburn, and it is sunburn rather than chronic sun exposure that is the main modifiable risk factor. Having multiple dysplastic nevi is also an increased risk. The most common sites are the legs of women and the backs of men. Beware subungual melanoma, melanoma beneath the nail, and acral lentiginous melanoma, which is melanoma on the palm or sole, which is rare but has a poor prognosis due to presenting late. This type of melanoma is particularly seen in darker skin types, where the estimation of skin cancer risk by both patient and doctor may be lower, resulting in a late diagnosis. The location on the bottom of the feet is also not helpful to early diagnosis. The same rules apply when looking at these with the ABCD criteria and maintaining vigilance when assessing these patients, even though their risk of dangerous skin cancer overall may be lower. Here are some more examples, including subungual melanoma and acrolentiginous melanoma in skin of colour. Treatment is with excision surgery. The absolute thickness of the melanoma is measured histologically, as this predicts prognosis. The thicker the tumour, the worse the prognosis. The thickness guides future treatment, which will include wide local excision of 1 to 2 centimetres, which reduces the risk of local recurrence only. Sentinel node biopsy may be of prognostic value, but is not therapeutic. Targeted therapy and immunotherapy are now available for some types of melanoma. So remember your ABCD rules. Look for the ugly duckling. Check people's feet. Secondary prevention doesn't work, that is, randomly mole checking people at festivals and events, and campaigns teaching the public how to spot early signs of skin cancer has been proven not to increase the pickup rate. Primary prevention does work, so take care in the sun, no matter your skin type, and be an advocate for good sun protection, especially for children. Don't forget to think about skin cancer in darker skin, even though the risk may be lower. Prognosis is often poorer, and so you have an opportunity to pick it up as early as you can. This is a fantastic free resource produced by the American Academy of Dermatology if you want to see what any skin condition looks like in skin of colour. It is freely available for the public and healthcare professionals, and the majority of the photographs are free to use under an open license. According to Wikipedia or their social media pages, or celebrity gossip pages, all these famous people have had skin cancer. Celebrity skin cancer patients have been important in driving sun awareness campaigns and cancer prevention. This has been an introduction to benign and malignant skin lesions. The name of our project is Dermoscopia, which is a non-profit organisation with the aim of increasing access to and use of dermoscopy in the diagnosis of skin lesions for the early detection of skin cancer by non-specialist health professionals, as well as rapid identification of benign lesions and safe reassurance of anxious patients. Dermoscopia demystifies dermoscopy for the non-specialist, as well as providing instructions for using budget devices where dermoscopy is not practical or affordable. We'd invite you to check out our resources, which are provided entirely free.